Well, first of all, thank you so much for inviting me along today, and really may I congratulate you as my kind of overwhelming sense of walking in this morning. First of all, I guess on the growth and the development and the buzz behind the Paediatric Society, and just looking at the programme that you've got today, it really looks outstanding. So congratulations. Your feedback will tell me whether this jump to this particular topic following the previous topic, whether that works or not. But there's no doubt that this could be considered an eclectic combination of talks. There are many privileges of working in medicine, and I just had the most incredible flashback there listening to Chris's talk, as because I recruited many babies to that original Epicure trial back in the mid-1990s, and that brings back some very fond memories for me. But what it also made me just reflect on there is that passage of time since the mid-1990s for me personally has gone in the blink of an eye, and it's gone in the blink of an eye because of the rewards that working in clinical medicine can provide, and I've just been occupied, and because I've been occupied, time has gone by in a blur, and you have a fantastic prospect ahead of you, and I wish you every great fortune for it. I'm going to mention my predecessor as the slides go on. But one thing Dr. Dewhurst kind of alluded to there was that I think the fascination of pathology, and I don't think we should hide or behind that. I don't think we should feel something unusual about having that sensation, about having that sense. There's no question that pathology, it does underpin medicine, of course it does. It is fascinating, it does maintain our interest. We of course don't wish pathology on any fellow human being, but it is the reality, and it does inspire us, it does maintain our interest. And in order to understand where there isn't pathology, definable tissue-related pathology, you of course need to understand tissue pathology. So my ward rounds can take me from intensive care, a patient with perhaps a multi-system inflammatory autoimmune disease, potentially musculoskeletal manifestations of other pathology like sepsis, like malignant disease, etc. But then my pathology can take me to a very profoundly disabled young person, wheelchair dependent, not accessing school, withdrawn from social care, in whom we can't define tissue damage. And in some respects, I think we can only come to the judgments about the lack of tissue pathology by understanding tissue pathology. So in the course of your careers, take every opportunity to get hands-on, to feel tissues, to understand patients. So I'm going to talk about a cohort, and there is a tendency with this cohort of patients to have a sort of to refer to perhaps the term heart sink patient, and I want to try, and again your feedback will tell me whether that's successful or not, to try and dispel one or two of those myths. So non-tissue damaging chronic pain in children and young people. So I'm going to talk a little bit about an approach to patients who find themselves in this predicament, touch a little bit on what epidemiology we know about, talk about pathophysiology, because there is some, and I think that actually can be both helpful in terms of how you work with the patient and the family, but also help ourselves. Touch a little bit on management of these young people, and a comment really about prognosis. Okay, so there are loads of definitions of pain. I'm sure you'll have come across them. This is the definition that works for me in practice, and it's one that I use. Pain is whatever the experienced person says it is, existing whenever or wherever they say that it does. I think that's reasonable. I think that, of course, in paediatrics, it may not be the patient that articulates that symptom, that of course, therefore, can have its potential challenges, because, you know, if it's a parent, a carer who's articulating this on behalf of someone, there can be lots of potentially confounding factors within there. Importantly, however, I think other definitions are also relevant. So the pain stimulus is interpreted based on context or meaning of the pain to the individual, as well as the individual's psychological state, culture, previous experience, and a host of other psychosocial variables. As a result, the same noxious stimulus may cause different amounts of pain in different individuals based on personal characteristics. If I develop a headache and a family member has recently developed a brain tumour, I may interpret that headache in a different way, and immediately that headache may feel different to me, as an example. And I think that this is something that we'll come back to. So, as we're all aware, pain is helpful. We've evolved pain as a species for some very good reasons. It's a warning sign. It's a response to potential tissue threat, to tissue damage. Helps us to locate. It has biological value to us as a symptom. It also, acute pain tends to respond to more traditional medical models, drugs, often, post-operative pain, post-trauma pain, etc. And fortunately, for most of us, most of the time, it's a self-limiting sensation. Treat the cause and the pain goes away and we get back to normal function. However, pain, of course, can become chronic. And chronic pain is different. It's not just prolonged acute pain. And it's hard. It's hard for us to understand. It's hard for patients to understand. It's hard for families to understand. And it's hard, of course, for us at times as clinicians to understand. There are not, in this context, easily identifiable inflammatory or other disease processes. We can run through our surgical sieve and we can't identify tissue pathology to help us understand, prognosticate, explain the cause of the pain. It's pain that persists beyond perhaps the usual course of an illness, the usual course of an injury. It clearly will ultimately have an impact on a patient's well-being. We can't measure it. We can only measure it by self-reports or perhaps behavioural responses until technology gives us, perhaps maybe through functional imaging or other technologies will help us to perhaps to define it in more physiological, biological ways. Pain that may originate from an initial physical trigger, but the trigger resolves and the pain becomes the disease. So effectively pain that's there when it shouldn't be there, and of course in that context it's not helpful to the patient. Now, in MSK practice, in rheumatology practice, but first and foremost as a general paediatrician who's developed a specialty interest, when I approach a patient with pain, I'll probably follow a surgical sieve type of path. So I'm looking for patterns. There are loads of causes of pain. I'm sure if we were to do an exercise we would find more causes than this. But I might, of course, be looking for a pattern of pain that's worse at rest, that may be indicative of an inflammatory process. Pain that's worse on movement, more of a mechanical process. Pain that's got some red flags, pervasive pain at night time, resulting in disability during the course of the day, with other clinical features that might alert me to a malignant mechanism. And of course there are other potential causes. So although the surgical sieve, when we meet patients with pain in whatever organ system that affects, although the surgical sieve may be very large, we can probably whittle that down quite quickly through a careful history. So I've put a couple of referral letters. They're real, just to sort of give us a little something to sort of to think about. So this is an orthopaedic colleague. I'd be grateful if you could review this 15-year-old young lady who comes from a family with a neuropathy. I understand her mother has been tested and she doesn't, so chances are the patient therefore doesn't. The young lady has always complained of pain in a variety of sites, for which she's had some physiotherapy. She fatigues easily. She's been to the paediatrist who's prescribed her insoles, and she's had physiotherapy duplicated. So she doesn't seem particularly hypermobile on examination. I'd be grateful if you could see her with regard to her total body pain. And I guess for some of us, that might just think, oh, right, here we go. That's not going to be a straightforward consultation. A second referral, I'd be grateful if you could see the 6-year-old boy with a year history of joint pain affecting knees, hips and shoulders. The pain has increased so much he finds it too painful to walk to school. A bit worrying, but a year history. No erythema, no swelling of joints, no associated fever, no nail changes or rashes. And the remainder of our examination is normal. So it would seem to me from those referrals that unless the referrer has missed some glaringly obvious pathology, that there's probably not going to be a tissue-related mechanism for this pain. But we've got, two pretty disabled young people at different ages who are going to need, who we're going to, try to help as best as we can. So how do we interpret that referral? Well, to me, I think it's unlikely that I'm going to find an organic disease, but I suspect I'm going to find some quite complex scenario that's going to need a little bit of unpicking. I mentioned my predecessor. He's called John Sills. I'm still in touch with him regularly now. He's retired, and he used the 3-letter abbreviation WGO. What's going on? What's the real story behind this presentation? And I think one of our many privileges in medicine is we get to work with people. We get to share a lot of very intimate or personal details about family life, family dynamics, relationships, etc. And I think chances are there's going to be other things going on in these families that are going to be relevant to these young people's experience of pain. However, could there be pathology that's been missed by the referrer? I think unlikely, but we have to remember that may be the case. In particular, the 6-year-old would worry me, because if a 6-year-old has got some emotional factors manifesting his pain, then that's a bit of an alarm bell. But equally, he's young, and young kids generally don't experience musculoskeletal pain quite as significant as this. So, could there be something a bit more sort of sinister medically in the background? Anyway, we've not got information to see them urgently, so generally these kids get into a routine slot. And we do what we do with all of our patients. We engage as best we can. And I find that a therapeutic history in a situation like this can be time well spent. So taking things seriously, listening to the story carefully, rather than being dismissive, which, believe me, sometimes there is a temptation to be, but taking some time, listening carefully can be a very, very worthwhile thing to do at this stage of a patient's journey. Of course, we need our history to help interpret our physical findings and then to define what, if any, investigations that we need to do. But you can probably imagine that, and you will have come across, I'm sure, on your journeys already, that patients who experience physical symptoms in the context perhaps of non-tissue damage or where there are adverse emotional facts in the background, that history can be challenging, and these are generally not happy scenarios and not happy young people and not happy families. So histories can become overwhelmed with distress in all manner of both the patients and the family life. So a young person presenting with chronic pain and fatigue may have an enormous impact on Social function, just going around from kind of 11 o'clock on the clock face. School can be catastrophically impaired. Sleep can be very disturbed. Physical activity disturbed. Independence totally impaired. Moods, sometimes quite difficult things to bring out in a consultation with a young person, but trying to just explore, what are your thoughts, feelings, emotions? Can you put into words? I'll often ask a question when a consultation is very focused on pain. I'll sort of say, are there any other words to describe, how you feel? And almost always, the conversation immediately comes back to the pain. I guess what I'm trying to do is trying to tease out, do you feel sad in any way? Do you feel stressed in any way? But I guess we just trying to sort of just draw away from what else is going on in this young person's life, other systems affected, an impact on family life, and of course all of these things very closely intertwined and interrelated. So moving on to the clinical examination, I think we will examine patients, I guess, to help us interpret that history. And I think there's something very fundamental about examining a patient. Are we fundamentally well or not? Now, I think in medicine, and certainly working in a hospital like this, we'll often hear in conversations, you'll come across it on ward rounds, and I do week in, week out. I'll have a comment like, such and such is well. And of course they're not well because they're in hospital and there's situations, but they're not critical and non-intensive care. And and often I think we'll use this term well in that to say someone's not septic, not about to die, but actually of course they're not well. But in this context is this child well in terms of, are their tissues healthy? Is the child's behaviour in keeping with the reported level of pain? It might be something like the child says that they can't walk. So we may get them onto a couch, lie them down. You try to passively raise the leg. They won't do it because of pain. But then we sort of say, right, I just need to examine your chest, and they'll sit up and let you examine the chest. So there's inconsistencies in the examination. It's not about trying to catch them out, but it's trying to understand what's going on with them physically. Does the child have an air of la belle indifference? I've just told you this catastrophic story about how impaired I am, but I'm actually almost smiling when I'm saying it. Can we define tissue pathology? Is there joint swelling? Objective signs. Is there objective signs of muscle weakness? Are our tissues tender? If so, where? If there is swelling, what's the nature of the swelling? Fluid, bone, soft tissue, etc. Is there any areas of allodynia? And I'll touch on this in a second. So allodynia is sort of an abnormal perception of a sense of pain to normal touch, and that characterises in many respects this clinical predicament. Colour changes, temperature changes, sweating changes, inconsistencies in the examination I just touched on, neurological dysfunction. What's the child-parent interaction? For students who sit with me in clinic, and some of you may have done, I don't know, but I'll often at the end just as an observer of that consultation, what's your sense? What was your sense of interaction? What did you make of mum, dad, granny, uncle? Something very sort of fundamental about people. Evidence of concurrent conversion symptoms. Children back pain. Are there red flags? What does it sort of? What does it feel like? So. I worked with a fabulous physiotherapy colleague again, who's retired, in the relatively recent past, and she developed this what's the word? Not an anagram, but trauma. So these patients who find their way eventually to services like mine have often been told many different stories about diagnosis. And some, they've been in clinics where there've been malignancy's been discussed, or infections been discussed, or they've gone clinic to clinic, doctor to doctor. They're often angry. They are often angry. A perception of not being believed, often by the child as well as the family. They're not best impressed. They're a bit confused, and they're certainly worried for a whole variety of different reasons. So, in terms of some specific musculoskeletal syndromes, that I think we can define non-tissue damaging pain into these kind of groups. Kids who've got pain everywhere. Not an easy group. Some will refer to the term juvenile fibromyalgia. We as a team have really tried very hard to avoid the term fibromyalgia because we don't find it's very helpful. Patients with more localised pain syndromes, complex regional pain syndrome. Kids who are hypermobile who experience pain, and kids with chronic back pain. So the kids with pain everywhere, it's often crept up over months or even years. It's everywhere. It can be associated with allodynia. So these kids have a very, they stub the toe and the pain lasts for weeks after the stub of the toe. They're often fatigued. They're often have disturbed sleep. They may have some day-night reversal, sleeping during the day, wakeful during the night. Mood is often phenomenally low, and trying to piece out whether are they feeling low because they have pain, or does feeling low drive the pain, or somewhere in between. These families often need a level investigation in order to move forward. It rarely will we be able to, I think always do we need to do a certain level of investigation, but we may have to do some quite intensive investigations in order to get the patient and the family on board with different models. Now, complex regional pain syndrome is a particularly fascinating group of conditions. So these are young people who, in children, it's usually there's no particular trigger. In adults, there's more likely to be a trauma trigger or a surgical trigger. But these kids who might have had something or nothing injury, but who then protect the limb. A limb then becomes exquisitely tender, untouchable. It becomes shiny skin. It may swell a little bit. Becomes often extremely cold to touch. There may be some sweating changes, and these kids, if you kind of read reports or blogs or what they tell you, give some most incredibly descriptive terminology about it's like having boiling water poured on my leg. It's like having a knife being stuck into my leg. So an incredibly painful group. Hypermobility and pain is fascinating. 10, 15, 20% of the population would be easily definable as hypermobile, but asymptomatic, or even find an advantage from it. We do have some quite worrying pathological hypermobility syndromes, of course, to consider, some potentially threatening hypermobility syndrome, Marfan's, vascular type, Ehlers-Danlos, etc. But this was my daughter. There's a theme not that long ago, and she's quite flexible. She found it an advantage for dance, gymnastics, etc. Unfortunately, doesn't appear to experience any discomfort as a result of being quite flexible. But others who have the same joint phenotype seem to get trapped in a vicious pain cycle, and it's really very hard to understand why that should be. And finally, chronic back pain, common, almost always posture related, but of course always needs to be taken seriously, particularly in children, and looking for our red flag triggers, nighttime, disabling pain during the course of the day, etc. Okay. But pain has an impact, of course, on the bigger family, and the greater family. I think that sort of sums that up in some respects. So sometimes, it's mum who's more who seems to be experiencing the distress. So, how many kids get pain? Well, we don't really know, because we'd have to get out into the population. This was a German study of school children, And about 80% of school kids, primary school and secondary school actually, reported some episode of pain in the preceding 3 months. But actually, 60%, 80% of kids reported pain in the previous 3 months. Of those, headaches were the commonest, tummy aches were the next common, throats, extremities, etc. So kids experience pain, usually it's self-limiting. However, there are, in this particular study, 22%, so the kind of 10, 11 o'clock of the circle, articulated pain that had persisted for more than 12 months. And that feels to me probably about right. And of those, of this cohort, if you add the two sort of bars, the percentage figures in each bar together, 60 odd percent experienced some sleep disturbance due to pain. Similar number reported at times they were unable to pursue their hobbies. It had an impact on their appetite, was keeping them away from school, and having an impact on social function. So this has, so persistent pain has an impact. Okay, so pain. I think to understand pain in a context of working with a patient, I think it does help just to reflect at in my case, a rather basic level as to what goes on. So here's our so in the periphery we have our pain receptors, the nociceptors, that will respond to potentially tissue damaging threats, heat in this case, and those nociceptors will fire signals down relatively quick transmitting A delta fibres, relatively slow transmitting C fibres, so our afferent pain signals, making connections within the dorsal horn of the spinal cord, crossing over to the lateral spinothalamic tract and ascending to our higher centres where we'll of course perceive and interpret that pain. And that perception, of course, has been shown in really quite robust studies. That perception is altered by factors such as mood, such as context, the family member with a headache, with a brain tumour, previous memories, previous expectation of pain. Within the spinal cord, we touched on, afferent pain fibres C and A delta, and they will be our pain facilitating, our pain pathways. A beta, rapid afferent transmission, will perhaps sort of transmit the pressure or the mechanical sort of touch. So bump your elbow, rub. It's the signals transmitted by the A beta fibres which will have an inhibitory effect on the pain pathway, and that of course is how a TENS machine would work. So we have this sort of balance between pain facilitation, helpful, pain inhibition when we of course need it. But if the afferent pain pathways continue to fire, what happens is that is the concept of sensitization. So the increase of neurotransmitter release will sensitize the pain pathway. That, of course, leads this concept of allodynia, the abnormal sensation of pain to light touch, and will start to inhibit the inhibition mechanism and start to for this pain to become more persistent. Now, I've yet to read a very convincing I don't think it exists as to why, in this context, what fundamentally is, in the absence of tissue mechanism, is making these pathways continue to be active, but they are continuing to be active. So we get this sort of sensitization. So the pathophysiology therefore depends on, so what's going on is we've got change in form and function at the neurobiological level, so neuroplasticity. We've got changes within the both pain we get this increased pain facilitation by sensitization within central methods, and loss of the normal modulation, all of which seem to sort of come together to make this sort of pain continue. And of course, in amongst all of this, there has to be emotional behavioural factors that are relevant. So then, when we then move on to sort of to try and then to manage, it's often useful, I find, to be able to explain those concepts to patients, because if I'm meeting a person with an inflammatory arthritis and I want to use drugs to suppress, modify the immune system response, I think in order to get buy-in from the patient as to why that should be, understanding the mechanism of the disease is important. And I think it's the same for persistent pain. So explanation. Explanation can go one of many ways when I start talking about this, and without doubt, no matter how careful I try to believe, to make the pain credible, to make the predicament credible, it's not uncommon for the family to leave clinic and go straight to pals to complain that Dr. Cleary has just told me that everything's in my head and nothing's and not believing me, and believe me, it happens all the time. 99% of my pals' issues are in this context. 10 minutes, thank you. That will be perfect. So explanation of the mechanism, what we believe is going on with why this pain is being perceived. I think often it's reassurance that it's safe to continue activity and it's safe to increase activity. The pain is not a warning sign of threat of tissue damage. And then the approach to management is very much underpinned by a biopsychosocial model and has to be multidisciplinary. And I guess I'm fortunate that I work within a multidisciplinary team that are enthusiastic and motivated to work with these young people and families. I think if you didn't have the back of a multidisciplinary team, it can be challenging. For those of you who find your way into primary care, you'll find a lot of this, and it will be fascinating to work with. You'll be able to engage with families in a primary care setting or in a secondary care or a tertiary care setting. And another way I'll approach the explanation is depending on, of course, on what level to pitch it with the patients and the families, might be something like this. Pain vicious circles. You experience pain. We can't define it by tissue damage. It's there. We believe it. But pain leads to protection, leads perhaps to some circulation changes, reduces your mobility, further drives the pain, decondition of muscles, etc. And we need to reverse that vicious circle. Exercise increasing mobility, decreasing in pain. So it might be that we draw out a diagram like this, and along those lines. But again, it's that engagement with the family, engagement with the young person. Drugs have their role. Generally speaking, traditional painkillers, paracetamol, non-steroidals, aren't particularly effective with persistent pain. And it's drugs like low-dose tricyclics, low-dose anticonvulsants, and they're effective because they inhibit the neurotransmitter pathways, the neurotransmitter-related signalling at central levels. So low-dose amitriptyline at night, low-dose gabapentin, much more likely to be effective alongside the physical and the psychological strategies. I pinched this slide off one of my psychology colleagues who did a much more detailed talk. But if we can get buy-in from the families to engage with psychologists, it can be an incredibly powerful adjunct to the medical and the physical strategies. And psychologists, of course, work both working individually with young people. They may work, of course, as a family group. Therapy is largely sort of CBT driven, but there may be some other strategies. It may be that some relaxation techniques are valuable, distraction techniques, but they very much do facilitate the work that we do as doctors and physiotherapists. And in my experience, clinical psychologists are very good at working within multidisciplinary teams. They're very good at coordinating teamwork. So cognitive behavioural therapy and other types of psychological strategies can be very powerful. Okay. So, on the whole, I certainly couldn't do this full time, but I find it a fascinating adjunct to some of perhaps the other areas of work that I do. 10, 15, 20% of my time probably around working with young people who find themselves in the predicament of chronic pain. And on the whole, these young people do extremely well, and I think almost certainly do better than adults who experience chronic pain. But I would consider them as a group who have a need, because if we can prevent young people, if we can prevent them becoming adults with chronic pain and ongoing disability, and I think we've done not just the patient but almost certainly society an advantage. So a bit eclectic. I'm not sure it follows beautifully on from the first talk, which I really did enjoy, and a bit different, but I hopefully just give you a little different view as to considering people like this as maybe not necessarily a heart sink scenario that it sometimes feels like it might be. So thank you for your attention.